Good Friday morning, everyone, and welcome to today's PHO webinar presentation, Orientation for IPAC Leads in Long-Term Care Session 2, Surveillance. My name is Boris Marufov, and I'm a team lead in IPAC PHO, and I have the pleasure of moderating our second session today. Before we begin with today's presentation, I will mention a few housekeeping items. The chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have any questions during the session. A discussion and question period will follow the presentation at the end, and the presentation slides and the recording will be made available in 2 weeks from now in our website. And if you have, in any point during today's session, have any questions, you experience any technical issues, please email capacitybuilding@oahpp.ca. And today's topic, surveillance, is my favorite subject. I've been supporting surveillance activities and initiatives for several years now, especially for long-term care sector. Surveillance allows you to collect valuable data to support decision-making based on real data. Now, let me introduce my colleagues, the speakers for today's presentation, Darius Pajak and Lori Schatzler. Darius Pajak is an IPAC specialist at PHO. Previously, Darius spent 15 years in both acute and long-term care settings, focusing on infection prevention and control, as well as local public health. Darius holds credentials in infection control and epidemiology and public health, and is a former member of Provincial Infectious Diseases Advisory Committee. Lori Schatzler is an IPAC infection prevention and control specialist with Public Health Ontario as well. And prior to PHO, Lori worked as an occupational health nurse in acute care, a primary care nurse with family health team, and as public health nurse with several public health units in Northeastern Ontario and Michigan. Lori has maintained her certifications in infection control and occupational health nursing, brings these areas of expertise to her current role with PHO. Now I will ask Lori to begin the presentation.
Wonderful. Thank you so much, boys, and welcome everyone to our second session. I am happy to have you all here today. I'm excited about this topic, and mainly because I always found the term surveillance quite intimidating, having a background as a public health nurse, OC health nurse, primary care nurse. I never thought I was doing surveillance, and once I realized, yes, I have been doing this all along, it became more reasonable and practical to me. So we hope by the end of this session, you're going to have the ability to have an understanding of surveillance as an overview to your IPAC program. We're going to walk you through the steps to planning a surveillance system, collecting that data, compiling it, and how to use it, interpret it, and present it to the people that can make a difference in your facility. We will go through a complementary resource that Public Health Ontario developed to support you with this webinar series, which is the orientation checklist for you. Darius and I will walk through the steps of surveillance, and we hope to have some time for questions and answers for you. So if you weren't at the last session, we did highlight this checklist for you that will help support you as a toolkit, a roadmap per se to walk you through the key areas of an IPAC program and your role. There will be links in this document for you to do some more homework on and reading on, and we'll certainly provide links in this presentation for you. The checklist does mirror the key components of an IPAC program that we'll be presenting in this webinar series. So before we jump into the components of surveillance, I think it's important to stop and pause to talk about what surveillance is and why it's important as part of an IPAC program. And I like to look at surveillance as kind of a two-part system. One is having a very organized way, an ongoing way of collecting information within your facility, within your home as part of your IPAC program. to improve specific areas of population health. So the first part is really gathering that information and manipulating it in a way that makes sense. The second part is really going beyond the collection of information and sharing that knowledge that you've gained by doing surveillance for those in your organization that can have a direct impact on it, placing resources where they're needed to improve health. And this is an initial step in supporting your IPAC program, reducing healthcare-associated infections, and improving quality of care. So the next question to ask yourself is, why should we do surveillance in long-term care homes? And I think what we mentioned in the first session is really looking at having a significant role in reducing healthcare-associated infections in long-term care. We know that the majority of these are preventable, and surveillance will really be the key to unlock the necessary steps and tools to help reduce that burden. We saw a huge disproportionate burden on your long-term care home residents with the COVID-19 pandemic in terms of severe outcomes of disease with morbidity and mortality. We've seen this all along with influenza illness in long-term care facilities and other acute respiratory infections. So reducing those infections, not just for your residents, but for your staff as well, anyone within your facility, to reduce that burden. You may want to also have other reasons for surveillance, establishing a baseline, for example, of what those healthcare-associated infection rates are within your facility, and being able to monitor that over time. You may want to monitor clusters or trends, and pick up on signs and symptoms to detect syndromic surveillance to put measures in place in the event you're detecting an outbreak. When you're planning a surveillance system, you want to identify those high-risk residents. We talked about acute respiratory infections and the burden of lower respiratory infections like influenza on your population. You may have residents that have indwelling devices like urinary catheters. You may have diabetics, immune compromised persons that you want to flag to do a targeted approach. And you're also able to detect your diseases of public health significant that you would be required to report to your local public health unit medical officer of health, and detect any emerging infectious diseases, anything new that we're seeing in your community that now you want to be monitoring and surveilling within your facility. And the other two things that are pretty neat is more of the prevention side of IPAC, and that's really seeing the effectiveness of IPAC measures. So you're able to have a baseline and then put improvement measures in place so that you can see improvements and improved outcomes, and you'll have data to support this. And the other piece is that you're going to be on the units, you're going to be visible, you're going to be creating awareness of the value and the importance of IPAC practices. You're going to be sharing that information not just with the decision makers, with your senior leadership, but you're going to be talking to staff on the units, and hopefully they'll be able to see the difference they're making on a daily basis. We've highlighted 4 different types of surveillance here. There are other types such as total surveillance or facility-wide surveillance, where you're monitoring every single thing you can, and that's just unreasonable to think of. So we like to look at it in 4 different areas. And one is targeted surveillance, which you're either targeting a specific area in your facility that might be at higher risk for acquired infections within your facility. You might be targeting a specific patient population, and you might be targeting any infection types. The process surveillance really looks at things you might not consider as surveillance, but you're doing more in the form of auditing. So monitoring processes such as your hand hygiene compliance or PPE donning and doffing. Those might be things that you do in the form of auditing to verify that procedures and standards are taking place, just like environmental cleaning. And your outcome surveillance is specific to looking at resident outcomes. So changes to their health status that are attributed to preceding care and service. And an example of that might be surveillance of healthcare-associated infection rates. This really demonstrates the efficacy of your IPAC programs and protecting not just your residents, but your healthcare providers and visitors within your facility to reduce those healthcare-associated infections and decrease in costs. Syndromic surveillance is where you're really looking at a cluster of symptoms. You do this all the time with line lists, daily lists to monitor symptoms, signs of symptoms with your residents and staff, but specific residents for those infections they are at risk of. They might be acute respiratory infections, urinary tract infections, skin infections, etc. Now we're going to walk through the steps of designing a surveillance system, and the first step is in the planning. We've mentioned a little bit about this. This is assessing the population, so really looking at the type of residents you're serving, what they're at risk for, and the most common types of invasive procedures that might be going on in your facility, and also looking at most common types of infections, and then any health concerns from the community in terms of communicating with your public health and what's going on in the surrounding area you're in that puts you at risk. When you're looking at selecting outcomes for surveillance, you're looking at what are you going to focus on in terms of preventable infections. So where can you make a difference? And what are the biggest risks that you want to focus on where you can influence the outcomes for your resident population, for your staff? So the lower respiratory tract infections, we talked about urinary tract infections, or maybe colonization with, or infections with antimicrobial organisms. And then we want to establish case definitions. And this is something that gives you the ability to compare your data over time within a clearly defined way with specific criteria. So as you're collecting information, you're going to collect it based on your case definitions. And this is determined through a couple of ways. And so depending on the information you want to collect might depend which source you used for case definitions. You could work with your public health unit, certainly, and your IPAC leads to determine this. But IPAC Canada has a long-term care infection surveillance definition criteria there if you're a member of IPAC Canada, and they also have some other supporting tools for that. The Society for Healthcare Epidemiology of America also has case definitions, and the Provincial Infectious Diseases Advisory Committee through Public Health Ontario as well. Their best practice documents surveillance of healthcare associated infections in patient and resident populations, and I believe that's Appendix D. We've provided some links at the bottom here, but we certainly have some resources at the end of this presentation for you. So once you've set up your planning, you want to start collecting your information. And this can be determined by doing a couple of things. You have your case definitions, you're looking at the outcomes you want to achieve, and you may have to collect information on residents during their stay or perhaps retrospectively after discharge. And there are a variety of sources to do that right on the units, in your computer databases for your lab reports, line lists, admission logs, and your diagnoses. What you're familiar with will be passive data collection, where you're relying on other staff to collect that information for you. It may require the least amount of work on your part and resources, but it also may be at risk for misclassification or underreporting of information that is necessary for you. Information may not meet the case criteria. So active data collection is really important, that you're actively going out and seeking that information on a daily basis. It does require a high level of IPAC lead support, but you'll get a greater level of sensitivity for the data that you're collating. And you're probably going to be doing a combination of both because you can't be everywhere at every place and time 24 hours a day. And once you collect your information, then you want to look at how you're going to store it and organize it. And there are a few different ways of doing this. IPAC Canada, as I mentioned, has resources for you. And one is a database. It's the Long-Term Care Surveillance Database and Reporting Tool in an electronic format that you can add your information. And your public health units may provide you with specific tools you could use. Other ones, there's your Microsoft Excel, which many of us are used to using, and the SAS software, which I'm not familiar with, but maybe some of you are that'd like to speak to that later. So I'm going to pass this over to Darius, and he'll walk you through the next steps of data analysis.
Perfect. Thank you so much, Lori. So as Lori mentioned at the beginning, so a lot of us, including myself at the beginning, find surveillance an intimidating topic to look at, partially because there's a lot of new terms that are being introduced, so that could be a little confusing. And the other part is mathematics. So a lot of people feel a little apprehensive when it comes to math. So I will cover a little bit of that in the next few slides. But overall, if you really look at it, it's quite basic. And as Lori mentioned, we've been doing surveillance for a while without us calling it surveillance. So a lot of you will find it novel to kind of give new terms to things you're already doing. But again, it will be something that is quite familiar. So as we looked at the beginning of the presentation, so analyzing data is quite integral as part of the definition of surveillance. But an important concept in surveillance and data analysis specifically is that of rates. So we'll cover that now. So a rate is actually quite a simple calculation. So that's kind of where your math comes in. But as you can see on this slide, the formula consists of just three parts. So there's a numerator, a denominator, and a constant. And we'll go over these in just a bit. So the X that you see on the screen is the numerator, and it simply represents the information you're gathering. So for example, the number of residents with a specific infection, so that would be your X. And this is essentially the number of cases you've already identified, and that was in the steps of data collection that Lori just talked about. Y is the denominator, and this represents the population from which the data is being gathered. For example, this may be one of the individual resident care units within your home. Or it could be a subpopulation within the home. So let's say those residents within the home who have a Foley catheter or other device inserted. And finally, we have K, which is our constant, which is the trickier concept for some individuals to grasp. But by using a constant, what we're doing is we're able to transform the result that we generate to make it a little bit more uniform and also make it eliminate some complicated things like fractions that make it tricky to decipher what the data is telling us. And the goal with using this constant is to have a result that's, as mentioned, a whole number, preferably one that has just one number to the left of the decimal point. And this, again, makes it easier to compare, but ultimately, when we relay the information to others, it makes it a lot easier to understand. So just to give you an example, so let's say you're going in for surgery and the surgeon is trying to relay to you what the risk of infection is with the procedure you're going to have. So if the surgeon were to tell you that the risk of infection is 0.001, what does that really mean? But if the surgeon tells you that the risk of infection is 1 in 1,000 cases or operations, that makes a lot more sense. And at least personally, I see that as a more relatable number when someone says 1 in 1,000. It really puts things into perspective. And the constant that allows us to do this can vary a little bit, and it varies based on the data we're looking at. And the constant could be either set at 100, at 1,000, like mentioned with the surgical example, at 10,000 or 100,000. And we'll have a few examples coming up to make it a little bit more clear. But as mentioned, the reason for assigning the constant is, again, to make things a little bit more salient and understandable. When looking at new colonizations, for example, of antimicrobial resistant organisms, and these are things like your MRSA, VRE, the constant that we typically use, or the K, would be 10,000. and it's based on resident days. So for infection types that might be more specific, such as device-associated infections like catheter-associated infections, or again, the surgical example I mentioned, we would use 1,000 for that. So it would be 1,000 catheter days as an example. For most surveillance programs, though, the nice thing is that a lot of this is quite standardized. A lot of the resources that Lori mentioned would actually go into these details and give you specific standardized approaches for doing things. So you don't have to sit there kind of figure out, oh, what should I use? Do I have to come up with my own constant or denominator? So the literature in infection control would kind of inform you of what needs to be done, as well as the case definitions that you would be following. So hopefully, to make things a little bit more clear, I'll give you some more examples. So the rates most often used for surveillance in long-term care homes are things like healthcare-acquired infections and device-associated infection rates. So let's look at these a little bit more clearly. So you could see on the slide here, occurrence of disease can be measured as either incidence or prevalence. So this was touched on a little bit earlier. Incidence rates, for example, are new cases of infection. And all of this, when we think of cases, we want to think about a period of time to put it into context, right? Especially for comparison's sake. So again, incidence would be new cases within a period of time, such as a month. And as you can see on the slide, here we use resident days, which is simply the number of days residents were at risk during a period of time or a period of concern. And in this example, we're looking at residents, let's say in the month of January, and knowing that January has 31 total days, the actual risk period would be 31 days. But this would be potentially adjusted because we want to dig a little bit further to see if it is accurate. So let's say one of the residents we're using this part of the calculation was out on pass for, let's say, a week of that 31-day period. So you do want to account for that because obviously for that week or 7-day period, the resident would not be at risk of infection because they would not be present as part of the population at home. So just some things to consider. The other measure of occurrence that we look at in infection control is prevalence. So this includes both new and existing cases in the population during a specific period of time. So again, that period of time is very important. And to distinguish this, I remember back when I started in infection control, I was told to decipher these two terms. The easiest way is to picture a running faucet, which sounds kind of odd. But basically, when you picture a running faucet, the water that's coming out of the faucet is your incidence. It's new cases, fresh water coming in. So new cases is the running water. And the water that's collecting in the basin or the sink is your prevalence. So you have the water that's already in the sink, but you're adding new cases, the incidence. So all that would be your burden of disease, which is the prevalence, new cases and existing cases. And this concept could also be further expanded by considering the drain, for example. So the drain as the water leaves, so that's cases leaving, and cases leave from being part of the prevalence to either recovery or death. And with that, it would kind of put things into perspective. So again, we have your prevalence, your incidence, and then the burden would be your prevalence. And that does obviously vary depending on what's going on. And in this situation, K again is the constant. And once again, it's for ease of comparison and things of that nature. So moving or continuing on with the data analysis section, as mentioned on the previous slide, rates can also be calculated from infections associated with medical devices. So this can include things like Foley catheters or enteral tubes. In the example here on this particular slide, you could see that X could be a number of infections for a given period. So as an example, the number of urinary tract infections diagnosed in residents who had a Foley catheter. And in this example, Y would be the number of device days, which we mentioned previously, for that month. So this way we capture the total number of days residents being followed had a Foley catheter actually inserted. And K again, which we mentioned is the constant, and here for device days, again, as mentioned earlier, would be 1,000. So it would be multiplied by 1,000 to get the 1,000 catheter days. There are some resources such as the IPAC Canada Toolkit, which we'll actually cover shortly, that will provide you a lot of assistance in terms of calculating these rates, as well as generating graphs and other things that make it a lot easier and more efficient when looking at this type of information analysis. So the next step in surveillance is data interpretation. As you probably already realize, every step in surveillance is quite crucial, and as is the accuracy of each step as you're executing it. And the reason for this is that any errors or omissions that could result during these periods of time will affect the data quality. And potentially this could lead to false conclusions. And the issue with that is that you certainly would not want to take action based on misinformation, because a lot of action would be implementing certain measures, removing certain activities, or stopping certain activities. So you want to make sure that you are reading information that's accurate. And things to consider during this data interpretation step includes things like having colleagues review rates that you generated. And the reason for that is it's always good to have a second pair of eyes. And this is almost a redundant step or a safeguard to make sure that the data you've collected and analyzed have been collected accurately and analyzed as they should be, so the information is accurate. If possible, you do want to compare your rates to previous surveillance periods within your home. This is often called internal benchmarking or looking at the baseline comparison from the past. And for some of you, based on the poll that we did, you may not be doing surveillance or not looking at certain aspects that you may be following in the future. So you may be missing that historical context, which may make it difficult for you to see if what you're looking at now is accurate. So with surveillance data, typically changes are very small, they're quite incremental. So you shouldn't see massive jumps and leaps. So it'd be nice if things that we do to transform a practice to result in massive fast changes, but it is usually quite slow. Changes that we see that are dramatic typically are actually for the worse. Often it's an outbreak or something has gone bad. Maybe there's a contaminated item that has been recalled, or something that leads to quite drastic impacts on our residents or patients. But for the most part, when we look at surveillance, the data shouldn't be changing that much, which is why you look at historical numbers, allows you to kind of be certain that what you're doing is accurate and that you didn't make any mistakes in your data. But again, you may be missing that historical context. So looking at other facilities may be an option, but the challenge here is that you want to make sure that you are very comparable. Because when you are doing surveillance, you're using specific definitions, you're looking at specific populations within your home. And if the other home or the data you're using from literature was looking at a different population, you're using different case definitions, the data is not comparable. And it really could throw you off to make you think that maybe your home is a lot worse, or may make you think that your home is a lot better than other homes, where in fact that may not be true just because the definitions are so varied. So that's an important aspect to consider. In any case, once you're confident that the data is accurate, it is definitely time to interpret the data and come up with some conclusions. If you do identify that the rate of specific infections is high, like mentioned, this may be a sign that something is wrong. So you do want to look into it, especially once you verified all the other factors that the data was actually collected accurately. But certain things that may result in the data looking a bit high would be potentially that you are collecting data that's revealed that there's an outbreak that is occurring. So if that's the case, you definitely would want to take action. So first you want to look back to make sure that there is indeed an action, or outbreak rather. You want to make sure that the case definitions for outbreak are being met and that everything is kind of accurate. And then you would obviously declare the outbreak, implement control measures, and involve local public health if it is a reportable disease. If it's not an outbreak, but the rates are still high, it's obviously something that warrants further investigation. And to narrow that down, you could use existing IPAC frameworks that you probably are familiar with. So most of you are probably very familiar with things like the chain of transmission. So the chain of transmission could actually be used to look back, because it shows you how things are transmitted. So if you use it to look back, it could actually give you a bit of a clue as to what the risk factors are, the contributing factors, and it may identify what the causes are for the spike in cases. Occasionally, however, no matter how much you look back in terms of what the infection rates are increasing by, it is difficult, or may be difficult, to find the actual source. So you may have to look at other factors, such as potentially issues with the surveillance approach, maybe the population changed. So over time, especially if you do have historical data, maybe you didn't realize, but the admission criteria for the home has changed. Obviously, the residents would have gotten older. Maybe more individuals are using certain devices. So all that could impact your rate. So you want to kind of look back. And one approach that we'll look at shortly may be useful in looking at what these infection rates could be resulting from. So moving on into the communication of results section. The next step is obviously you want to communicate the results that you have put together, regardless of what they are. With this, the old saying of no news is good news is not something that works well here. You definitely want to relay findings. Even if you have good news, even if the findings are great, you still want to relay them to everyone that's there because it is very important. So you want to inform the stakeholders involved. You want to inform the Infection Prevention Control Committee at your home. As well, you want to make sure that anyone that's impacted by this information is notified. And again, by impacted, I don't mean negatively. Even if it's a positive impact, you want to make sure you share that because it's definitely great for morale. And it's also useful for reinforcing IPAC practice because it just shows that what is being done, and if it is being done well, it's positive and we want it to continue and even improve further. So continuing on with the communication of results, in terms of approaches to communication results, so there's various approaches. So you have verbal, written, visual messaging. So for this, you want to make sure that you include aids, graphs, reports as appropriate. Regardless of approach, you do want to make sure the information relayed is timely, especially if the information warrants immediate action. And just from personal examples, if you are going to be declaring an outbreak on a Friday before a long weekend, you want to make sure that the individuals who do staff scheduling are fully aware that you will be declaring an outbreak before a long weekend, and make sure you do that as early as possible. And also, if there's a resident admission coordinator, make sure that that individual is also aware, because you don't want a new admission going up to an outbreak unit because individuals are not aware kind of what's going on in the home. So timely dissemination of results and information is very crucial to make sure that the home is operating well. And now with our last section, which is equally important, we're going to talk a little bit about evaluation. So with evaluation, we can divide this into two parts. So there is process and outcome. So if you recall, just on the previous slide, I mentioned high infection rates, and potentially you may be at a crossroads where you have high rates and you're not really able to figure out what the result is or what the causes or contributing factor to those high rates. So this is where process evaluation may come into place, where you could pinpoint sources. So these are very useful concepts, and it allows you kind of broaden your approach to IPAC and use all the little tools that are at your disposal in your toolbox to kind of figure out what's going on. So as the name implies, a process evaluation tells us about the function of a process, whether it's working as it should. And we can evaluate everything using this type of approach. So for example, compliance and steps related to Foley catheter insertion or management. So those are things we could use evaluations of processes for. To evaluate surveillance systems, the surveillance system itself, we could use process evaluation. So I made some comments earlier about making sure that your surveillance system is set up appropriately and that you are diligent in making sure that each step is properly executed so the information is reliable. So occasionally you may want to undertake a surveillance system assessment, and a process evaluation is what you would use to make sure all these measures that you're taking are accurate and actually being followed appropriately. The other approach to evaluation is to look at outcomes, which Lori touched on earlier. And much like the example we've looked at in the previous slides related to infection rates, these are the results of actions or inactions. And they can, to an extent, reveal consequences of practice, right? So we look at infection rates to kind of give us a signal of what's going on. So obviously looking at preventative factors is key. We don't want to wait for infections to tell us how to act, but obviously monitoring what's going on is very important because it allows us to structure and modify the program to ensure that we are targeting the things that are most salient and most important and relevant. Using an example, we'll talk about C. diff for a bit. So if you're looking at C. difficile infection rate, so obviously the outcome measure would be the incidence of infection. So we mentioned dot concept incidence. So incidence of infections, so new infections would be an outcome we track. But at the same time, we may want to pair this up with a process evaluation where we would be examining the adequacy of various measures. So let's say cleaning protocols prior to discontinuation of precautions. So that's a process we would want to look at, especially if we're seeing an increase in C. difficile rates. Or you may be wanting to look at antibiotic utilization within your home. So that's, again, an example of a process evaluation. Here we have an example of a process evaluation in action. And if we want to evaluate whether we are holding true to the case definition, and that's kind of touches on what we mentioned earlier, for UTIs as an example, during our data collection step, we can take some measures or approaches that are outlined here to actually look at this. This includes performing chart reviews or audits to make sure what we're finding is accurate. Having others verify the approach used for assessing and finding cases. So that's, again, very important because we want to verify that our approaches are indeed applied accurately. And also ensuring that you have built-in mechanisms to promote data quality. And this is overall continuous quality improvement at each step of surveillance, as mentioned. One thing to keep in mind is that when you do change or modify your approach, so obviously as you're improving things, you are going to modify how you are doing things. So you want to make sure that is reflected, because as you acquire data and you have baseline data, historically baseline data you could reference, you want to make sure that you very clearly kind of draw a line in the sand where things have changed. So if you modified a way of case finding, you want to make sure that's reflected in a graph or some other visual information that you're representing, so people know that if there is a blip, if there is a bit of a change, that may be reflected in the change that occurred in the approach to surveillance that was being done. So that's something to keep in mind and account for as well. So one thing I did want to touch on is the long-term care surveillance toolkit. So I know we've covered quite a bit of information, including some new concepts that may be new to you or not, but there are resources out there that aim to make the subject of surveillance approachable and practical. And one of these is this document, which was created in a collaboration with Public Health Ontario and IPAC Canada. And this is a nice comprehensive resource that allows you to set up a surveillance system in your home if you do not have one, or at least assess yours through maybe a process evaluation to see if the system you have is accurate and is reflecting this guidance. The added benefit here is that this document allows for a bit of customization, and also it's a resource that has a webinar that's linked to it, so it kind of brings some of the information to life, which is quite nice. So in this, our second session for the series of webinars, we've covered the fundamentals of surveillance in long-term care homes. So this is truly just the launching pad to the vast resources that are out there. We have obviously displayed quite a few slides of information. And for some of you, again, this may be the beginning, but it gives you some perspective of what surveillance is about. One resource I did want to pinpoint, so these are some additional resources, but one that I did want to pinpoint is the last one, so bullet number 3. So this resource discusses requirements for surveillance programs. So it's a good kind of adjunct to the long-term care toolkit that I just talked about. And it's important to use because as IPAC leads, it's very important that you familiarize yourselves with the epidemiology of the various diseases that are actually circulating in the community, especially respiratory diseases such as influenza. So you are familiar with the various things that are out there and how they may affect your home.
Thank you very much, Lori and Darius, and it was very interesting. And everyone, please put and write your questions in the Q&A pod, and we will answer that. We have a couple things there, a couple questions were there, and I've answered. And please continue to place your questions out there, and we will address them. And also, I wanted to highlight a couple things, as surveillance, as I said, is my favorite subject. Although, as we mentioned earlier, it sounds maybe a bit complex, like the rates, incident rate, prevalence rate, and all of that. A couple of things I wanted to highlight here is the one is, you know, you all do surveillance. Mostly everyone does a data collection part of it. But the most interesting facts and interesting findings can be found after you do the data analysis. When you compile the data and do the analysis and see, you will be able to see some trends, and that might be interesting. So I call everyone to try out that one. And also I compare surveillance. I try to bring some analogies with the surveillance. Is basically surveillance is like the same way as, you know, in other areas, people look and for any other suspicious activity. And for us, it's basically microorganisms. We are looking for them. And if we find anything suspicious, we try to jump in and resolve the issue, right? And also, there was a question about the comparison and about the absolute data. I answered already, just to highlight one more time, that absolute data is good in kind of a general understanding of your own particular home, because you know your home, right? Today is one case, tomorrow is 5 cases in a similar home, in the same home, and you will be able to compare because it talks about the same home. But when you talk to your colleagues, to other homes, and as I provided the example of UTI, if you say, I have 10 cases of UTI or MRSA or C. diff, or whatever the infection, and your colleague says, oh, I have 20, but the denominator, the language we used here, might be totally different. So one home can be 100 residence home, and other one could be even like 400 resident home. And that's why, you know, the 400 resident home saying that I have 20 cases, it may sound, wow, you have more cases, but actually it is less. So surveillance is such a subject that we want to use the common language, be able to compare with one another and compare the trends from the month to month, for example, from season to season. That's why basically we know and always talk about respiratory season, when respiratory infections go up usually, and we see that everywhere, not only in particular home. And those are some of the things I wanted to share with you. And I have questions here, so I will go to unanswered questions. Would it be helpful to provide some real life examples to learn how to calculate surveillance rate? Maybe there is, I already provide some numbers. Maybe there is, you can try out with another example on that one.
For sure, yeah. Overall, I guess the intent of this session is to provide you with a general introduction to surveillance. So we talked about concepts and some definitions, but in terms of actual working examples, that's where the resources that we mentioned in the actual resource section, the toolkit from PHO and IPAC Canada. So those resources would be a lot more helpful in terms of practical day-to-day applicable kind of examples you could get, where it would allow you to actually use the real data from your home, which would make it a lot more kind of understandable and relatable. So I think the overall intent here was just to introduce the concepts, and the actual practical, where in terms of like a working example, would be in those resources we alluded to.
Yeah, and also to mention one more time that this recording and the slides will be available in our website. We mentioned it several times. One more time, mentioning that in 2 weeks, about 2 weeks from now, it will be available on our website. So you will be able to go back, put the recording back, and then listen again, and you know, do it more than one times, maybe if you feel, and kind of learn more on surveillance. And it's definitely not you know, the comprehensive information we are providing to you. That's why we call the series of these webinars orientation. So it is kind of the entry to all these areas. And the resources we provided and will provide in our website, basically all will guide you how to build further your skills.
Boys, I'll just add one more comment onto Darius's, and long-term care homes are already working with their public health units in supporting outbreak management. And I know many of the homes work the health units work proactively with them along with their IPAC hubs to put in prevention strategies. So kind of looking retrospectively at that data from an outbreak and learning from it to help put prevention strategies in place down the road. So it is one more tool in your toolbox.
Yes, and thank you, Lori. And also to remind everyone that you have other partners, like Public Health Unit is one, and another system created in Ontario System of Support for Long-Term Care Homes is IPAC Hubs. So you can refer to them for some support. And also, we put at the end of this presentation the slide with the email contact, so you can contact us also if you have any specific questions. I will go for next question. Also, is there a calculator to plug in the unique numbers of surveillance rate? Actually, the surveillance toolkit mentioned by our presenters in IPAC Canada website, which we originally developed in collaboration in Public Health Ontario and then made it available through IPAC Canada to everyone, has that built-in Excel forms. When you have it and start to use them, when you put the absolute numbers, there is a formula behind an Excel sheet. It will calculate for you the rate. Yes, it is available. And the next question, catheter-associated urinary tract infection surveillance focus is valuable for long-term care homes. I will let Lori or Darius take on this, is about how valuable is catheter-associated UTIs in long-term care homes.
Well, I think what I mentioned earlier is when you're looking at your population-based, and what Darius mentioned is looking that you could have device-associated infections, and so recognizing what the risks in your population are for that, as well as the risks in your resident population for those infections. So certainly just like antibiotic-resistant organisms and respiratory infections, urinary tract infections would be one that would be appropriate to monitor in long-term care based on your population. Don't know, Darius, if you have anything else to add to that.
No, for sure. And as Lori mentioned in her piece about passive and active surveillance, so it depends kind of what's going on in the home as well. So maybe through passive surveillance, you see that there's a lot of positive results coming in and you're kind of attributing it potentially to a catheter or other such device. So that may spur you to realize that there is an issue within the home and that would warrant setting up a proper, fulsome kind of assessment or surveillance system in place. But we do have resources to Public Health Ontario specifically about UTIs, so that would be very helpful to look at, for sure. And just touching back on a previous question in terms of analyzing data, because I think that's a little issue that people have, quite a big issue in terms of the mathematics. And there may be resources within your home as well. So most facilities outside of IPAC do use rates and other such calculations for quality improvement and other measures. So your leadership would be looking at rates quite often. So there's most likely someone within your home, a resource you could connect with that routinely uses rates and calculates rates for other things. And maybe they can help in terms of calculating, and even they may be able to provide resources to information within the home that you could gather some baselines or other information. So I think looking within is helpful as well.
Okay, thank you very much. And I see there are no more questions in the Q&A pod. And thanks again for participation and active participation and for your questions. and it was very good participation. And thank you, Darius and Lori, for your presentation. And you may, after this, receive a brief and anonymous survey for today's session. And please try to complete this to help us to improve our programming and to access past presentations and review confirmed upcoming sessions. Please visit the PHO website. And we already shared with you the expected days for the upcoming sessions on this series. So we finished 2 and we have 4 more to go. Thank you very much and have a wonderful day, the rest of the day and weekend.